Hi, I'm Hirotoshi Ishiwatari from Shizuoka Cancer Center, Japan. I'm honored to chair our study recently published in gastrointestinal endoscopy. I will explain you the reasons to do this study and the results. First, I will explain the background of the study. EUS-BD is a rescue procedure when ERCP fails. Although there are several methods regarding EUS-BD, when patients have duodenal obstructions or surgical altered anatomy, we can choose EUS-HGS or EUS-guided antegrade stenting. However, these procedures have two major disadvantages. One is a biliary peritonitis, which occurs right after the procedure. And the other is recurring biliary obstructions. A method combining the antegrade stenting followed by EUS-HGS, we call it EUS-HGAS, has been reported, and this technique may overcome these disadvantages because it has two biliary drainage routes. Therefore, the possible benefits of this technique may lead to less peritonitis and a longer time to recurrent biliary obstruction. On the other hand, we have to consider the possible risk of pancreatitis after antegrade stenting, and the technique is definitely costly. Although no prospective study has compared the two, there have been 3 retrospective single-center studies. One of them is from our institution. From data, peritonitis occurred more frequently in the HGS group, while pancreatitis was seen only in the HGAS group. Furthermore, a longer time to recurrent biliary obstruction was shown in the 2 studies. These retrospective studies have some limitations, which include small sample size, the comparison between different patients' background, and selection bias due to the retrospective nature of the study. Therefore, we conducted a retrospective multicenter study to compare the outcome between HGS and HGAS using propensity score matching. We retrospectively collected data from 5 institutions in Japan. Inclusion criteria was patients with malignant distal biliary obstruction for whom EUS-HGS or HGAS was attempted. Patients with duodenal obstruction on the anal side of the major duodenal papilla and the use of a plastic stent in the HGS group were excluded. Regarding the selection of adding antegrade stenting, as it was a retrospective study, there was no clear criteria. It was done based on the endoscopist's preference. However, potential benefits of adding antegrade stenting include reducing the risk of viral peritonitis and postoperative cholangitis, as well as prolonging the duration of stent patency. These potential benefits might have influenced the selection, potentially favoring antegrade stenting for patients with pre-procedural cholangitis and with a longer expected prognosis. Study measurements include technical success, adverse events within 14 days, time to recurrent biliary obstruction, TRBO, and survival time. We balanced the 2 groups using a propensity score matching method and then compared items. The covariates for calculating the propensity score were the cause of ERCP failure, primary site of cancer, pre-procedural cholangitis, and total bilirubin level. This is a patient flow of the study. Of 360 patients who were collected from 5 institutions, 283 patients fulfilled the inclusion and exclusion criteria. After matching the 2 groups, we compared 81 patients of each group. Patient characteristics are shown in 2 slides. In the pre-matched cohort, differences were seen in age, primary site of cancer, and cause of ERCP, pre-procedural cholangitis, total bilirubin level, and history of placement of stent by ERCP. and two groups were balanced by a propensity score matching, except for age. I'll move on to the outcome of EUS-HGS and HGAS. The rate of technical success was similar between the two groups. Technical failure was seen in 3 patients in each group. In the HGS group, a stent was misplaced in 2 patients and a guide wire was impossible to insert to the bile duct in 1 patient. In the HGAS group, insertion of a stent beyond the biliary obstruction ended in failure in 3 patients, although HGS was successful in all patients. The puncture site was similar, and antegrade stenting was performed across the duodenal major papilla in 74% of the HGAS group. The slide shows the details of stent used for HGS and antegrade stenting. In the HGAS group, a plastic stent was used for HGS in 11 patients. Regarding antegrade stenting, a non-cover metal stent was used for 76% of the patients. Next, I'll share the adverse events after the endoscopic treatment. The overall adverse events rates were similar. The rate of peritonitis and pancreatitis, which were our main concerns, was similar between the two groups. No difference was also found in other adverse events. In terms of the severity of adverse events, more severe events seem more frequent in the HGS group. However, there was no significant difference. Finally, we compared TRBO and survival time. TRBO in the HGS group was significantly longer than that in the HGS group, although survival time was similar. Additionally, we evaluated the cumulative risk analysis of RBO when death was treated as a competing event. The cumulative incidence of HGS was significantly higher than that of HGAS. In conclusion, HGAS prolonged TRBO compared with HGS, although HGAS did not reduce the rate of biliary peritonitis. Before ending, I would like to thank the related institutions for the help to carry out this study. Thank you for your attention. From Japan.